every good thing has to end one day. And we are also now reaching to the last session of this 2 days voyage on Guidelines 2019. And for the last deliberation, let me invite Dr. Harjit Dumra for VT and P. He has already been introduced in the morning session and needs no introduction again.
Fine. That picture of Dr. Aspirin wearing the turban was probably woke all of you up, and I hope this last session keeps you awake as well. I know it's like a thunderclap headache after 2 days, but don't worry, none of you is going to get an SAH. So, I'm going to follow the same pattern as I did in my first talk. These are the guidelines you need to focus on if you really want to learn about embolism and deep venous thrombosis. The first one is the European Heart Journal with the European Society of Cardiology guidelines, came out in 2014. Then the chest guidelines in 2016, and the very recent American Society of Hematology. This is primarily regarding anticoagulation therapy, and that is the latest guideline. We're going to focus on these three for the next 20 minutes. And like I said in my first talk, if you have any issues, you can go through these guidelines or talk to me later on. I'm going to wind my talk around a case as I did with the first one. This one is for real, so probably I'll give you the outcome. Okay, so this is a 57-year-old gentleman, smoker, hypertensive, came to the clinic with a history of low-grade fever, cough, shortness of breath, streaking hemoptysis, and left-sided chest pain since the last 5 days. Vitals are normal, saturations on room air borderline around 93. X-ray chest is done, shows minimal left-sided diffusion. ECG at this point of time is normal. This is a presentation for embolism, so I'm not going to ask what this is. So this, we suspected an embolism. A D-dimer and a trope was asked for in addition to other investigations. The trope is negative, the D-dimer is positive. An echo is done, which shows no abnormality. Suspecting an embolism, a CT pulmonary angio is asked for. So the CTPA, this is the report. It reports an isolated filling defect in the left lower lobe segmental artery suggestive of embolism. Now this is the question for you. Would you initiate anticoagulants in this patient? Yes, no, I need more data. Isolated filling defect, left lower lobe subsegmental artery. Okay, you really need to read the guidelines. Anyway, let's move forward. So why are we talking about embolism? Simply speaking, it's a dreaded disease in the ICU. Nearly half of your PEs occur in the hospital. In fact, 16 to 25% of them develop shock, leading on to death. And most of these deaths might occur in the first hour of presentation. Not only that, thromboembolism is associated with long-term morbidity in the form of recurrence, post-thrombotic syndrome, and chronic thromboembolic pulmonary hypertension, which means our patients are going to suffer from this disorder down the line. They're going to be morbid, and a lot of expenses will be incurred over the next decade if these problems are not treated well up front. So a single important, accurate diagnosis and optimal management by the intensivist cuts down on all of these down the line. That's why it's important. So how do you go forward? First and foremost, as all of you know, this is not something new for you. You suspect on the basis of prediction scores, the Wells and the Geneva scores, on the basis of a D-dimer. Secondly, you confirm diagnosis, and the CT pulmonary angiography is the gold standard, as all of you know. In the ICU, if the patient cannot be mobilized, you resort to a compression ultrasonography for DVT or an echocardiography. If the patient can be mobilized and there is some contraindication for CT angio, you subject the patient to a VQ scan. Simultaneously, you assess severity because the next step is management. And that is on the basis of cardiac biomarkers like tropes and BNP, or on the basis of imaging on echo, or if you have subjected the patient to a CT, RV function, pulmonary artery diameters would tell you about the severity of this embolism. So what about the D-dimer, which is important? All of us ask for D-dimers. Remember, the first thing is you need to ask for D-dimers only in patients who have low or intermediate probability. So if you have a very strong suspicion of embolism, don't ask for a D-dimer. You can go straight away for an angio. But in the hospital, most of the patients are going to have positive D-dimers, and most of us have access to CT angios, so our patients are being subjected to excessive CT pulmonary angios. And the simple reason is because the D dimer is positive. And hence, there is this recommendation that for patients above 50, you need to modify your D dimer cutoffs. And you take this as the formula, age in years above 50 into 10. So if the patient is 75 years old, instead of 500 as the cutoff, you take 750 as the cutoff. And this decreases the incidence of a false positive pulmonary angiography happening. And you can prevent angiographies in almost 30% of your patients. If you used 500 as the cutoff in a patient of 75, you would probably have subjected him to extra 25% CTPAs. So simply by modifying your cutoffs, you can decrease the number of CTPAs that you are asking for. So coming back to subsegmental embolism. So these are lobar, then segmental, and then subsequently subsegmental arteries. So we are looking at an embolism somewhere right here in the left lower lobe pulmonary artery. So do we treat subsegmental pulmonary embolisms? So remember, the report is isolated, single. So why do we doubt this report? First and foremost, like I said, we've been asking for CTPAs far too frequently, and hence there is always a probability that you'll pick up a false positive filling defect, which will be labeled as pulmonary embolism, which might not necessarily be one. Secondly, a small subsegmental PE will arise from a very small DVT like a calf vein or a very small upper limb vein. So the chances of recurrence might be very less, and you might end up over-treating the patient. So what would you look for on a CT which will give you a clue that this subsegmental embolism is genuinely an embolism? Well, you look for multiple defects rather than a single defect, more proximal. The defect should be surrounded by a contrast rather than being eccentric. The patient should be symptomatic, and there should be high clinical test probability. That means the patient, before you sent him for a CT, you had a high test probability. Now, if you still have a doubt, the next thing you do is you look for DVT, because if you have DVT, then that subsegmental defect is genuinely an embolism. Whereas if you do not have a DVT, you can follow up this patient without giving anticoagulation at this point of time. And if this patient does worsen, or if you pick up a DVT on serial examination, then you can go on to treat. However, there are certain groups of patients where even a single subsegmental defect is extremely important. Which are these patients? Hospitalized patients who have reduced mobility, patients with active cancer, unprovoked DVT where there are no reversible risk factors, and patients who have very poor cardiopulmonary reserve. So in this group of patients, even if you have the slightest doubts, it is better to treat rather than to avoid, because you might end up missing that window which will help you treat your patients. So coming back to the case, this patient was subjected to an ultrasound which was suggestive of DVT in the right femoral artery. Hence, this patient now has DVT with the subsegmental embolism. Remember, most of the DVTs are localized to distal veins, not in the proximal veins, as you can see, and upper limb and lower limb DVTs are quite common. Particularly in the upper limbs, you would see DVTs because of excess use of central venous catheters. So when scanning or searching for DVT, do not neglect the upper limb, particularly if you have a central venous catheter. So coming back to this case, how would you initiate treatment? And you have 4 options. This is a patient with proximal DVT with a subsegmental embolism, and you have 4 options. LMWH, fine, that looks pretty good. Let's see what the literature says. Let's come to the management of DVT. There was a section that it has to include DVT, so I've included a few slides on management of just DVT. The management of proximal and distal DVT differs. When I talk about distal DVT, it is calf vein DVT. Proximal is anything proximal to that. So for proximal DVT, anticoagulant therapy is still the norm, and in a small subgroup of patients, you would subject them to what is called catheter-directed thrombolysis. I'll come back to that a little later. What about distal DVT? Distal DVT basically is less likely to embolize, and you have the option of waiting and watching in a small subgroup of patients who might not end up progressing or embolizing, or you can go ahead with treatment if they are at risk of thrombosis worsening or developing embolism. And there are certain criteria which will help to guide you as to that. You can go to the guidelines and read those criteria in detail, but for isolated distal vein DVT, you have the option of waiting, provided the chances of progression are less. What about catheter-directed thrombolysis? Thrombolytic therapy for DVT is a new kind of a phenomena. if you talk to vascular surgeons, they are very prone to moving forward for catheter-directed thrombolysis in most case scenarios. The only indication which is very strong is massive proximal DVT, ileofemoral thrombosis, and it is associated with life-threatening ischemia, particularly if it is less than 14 days. So that possibly is the only strong indication where you would subject a patient of DVT for thrombolysis. A Cochrane review found that the incidence of post-thrombotic syndrome was reduced by 1/3 when compared to anticoagulation alone when you thrombolized proximal DVT. But there was no difference in mortality or recurrence rates. So it cuts down on the rates of post-thrombotic syndrome, but nothing else. However, recently this article came out in the NEJM in 2017, which was absolutely a turnaround from the Cochrane analysis, and this showed no improvement in post-thrombotic syndrome, whether you use thrombolytics with pharmacological means to sort of lyse the thrombus versus pure anticoagulation. So at this point of time, the jury is still out whether you should really thrombolize your patients with DVT. Coming on to embolism. So this is the spectrum of pulmonary embolism. The presentations can vary from stable hemodynamics to gross shock. And basically, the severity of pulmonary embolism is not guided by the amount of clot in the pulmonary vessel. It is by the hemodynamic presentation. So you can have a small clot in a patient with a poor cardiopulmonary reserve who will present in shock and needs to be thrombolized. And you can have a massive clot in bilateral pulmonary arteries in a young patient who will present with cardiac stability and will not need thrombolysis. So don't go by the size of the clot in the pulmonary artery. Look at the cardiopulmonary status before considering thrombolysis. So based on the severity, the patient is classified into high risk, intermediate risk, and low risk. And we use clinical parameters, prediction scores, and again cardiac biomarkers. So if the patient is in shock, this is a patient with severe embolism. You use what is called the simplified PEITHO score, where you have several clinical criteria to help to identify whether the chances of mortality are high or low. So a simplified PEITHO of 0 predicts a 1% mortality at 30 days, and anything greater than 1, the mortality goes up to 11%. In our patient, the simplified PEITHO was 0. And besides clinical parameters, you look at cardiac biomarkers and the echo, particularly for RV dilatation and hypokinesias or signs of pressure overload, which will tell you that this is a strained right ventricle indicating severe obstruction. Remember, the echo might be a very sensitive investigation. It is not specific, but in a patient with shock, if you have no RV dysfunction, that rules out embolism. So shock, no RV dysfunction, no embolism. Shock, RV dysfunction, thrombolize the patient because there is a strong probability. So depending on the biomarkers, the clinical parameters, and the echo findings, you classify pulmonary embolism into low, intermediate, and high severity. And the intermediate variety is divided into intermediate low, where none of the biomarkers are positive, only the PEITHO is positive, and intermediate high, where the patient is not in shock, but has biomarker positive and PEITHO positive. So these are the four parameters which you, four levels of severity based on which you start treatment. So how do you treat these patients with pulmonary embolism? The first and the most important part is look for shock or hypotension. If the patient is in shock, the patient is high risk. If the patient is not in shock, then you look at the PEITHO score, followed by cardiac biomarkers and the echo. If cardiac biomarkers are positive and the echo shows RV dysfunction, the patient is intermediate high risk. If only one is positive, low risk. And if none of these are positive and only the PEITHO is positive, this is the lowest risk. So like I said, the spectrum ranges from low risk to high risk. So how do you treat patients of pulmonary embolism? And all of you know this. The guidelines clearly say that you start with low molecular weight heparin, you have an option of fondaparinux, and this is followed by warfarin. Or now you have the DOACs, the direct oral anticoagulants, rivaroxaban or apixaban. But if you are going to use dabigatran, it should be preceded by parenteral anticoagulation. No specific reason, the trials were designed as that. That is why for dabigatran, you need to initiate with heparin. These are some of the LMWHs you commonly use and the dosages. A word of caution, In patients with persistent significant hypotension and severe renal failure, it's best to avoid LMWH and you go with unfractionated heparin. What about obesity and renal failure? Because these are two things which you will face in the ICU. So for obesity, the guideline says go by the weight of the patient if you are going to use LMWH. So if the patient weighs 140, go by 140. Do not titrate the doses like enoxaparin 0.6 BD. That is the wrong dose. Don't be worried about overdosing just because the patient has a high body weight. Guidelines clearly say these patients will not bleed. You need to dose according to body weight. What about renal dysfunction? It is best to switch over to unfractionated heparin, but if you want to use LMWH, there is no role for monitoring anti-10A. It's best to go with the guidelines prescribed in the literature. So with enoxaparin, you can still dose if the creatinine clearance is above 30, but below 30, it's best to avoid LMWH. So this patient was started on enoxaparin 0.8 ml sub-Q BD. He was 82 kgs. 72 hours down the line, the patient worsened, went into acute distress, increasing oxygen requirements, tachycardic and hypertensive. This time his BNP is positive. TROP was repeated and is positive, and echo now shows mild RV dysfunction. Remember, he is on an anticoagulant. What would you do for this patient? And you have these 6 options. Can we have the voting? Shift to the ICU with the trial of NIVs, continue same treatment. Shift to unfractionated heparin, thrombolyze, thromboembolectomy, that's surgery, filter, rule out other causes. Okay, so that's good. So most of you would thrombolyze, and that is what possibly is the best way to move forward. Some pointers to what other management in the ICU, remember, if these patients get ventilated, cautious use of PEEP, because PEEP increases afterload and leads to further RV dysfunction. So PEEPs in moderation. Modest fluid challenges, don't overload these patients, they will go into RV dysfunction. You can use inotropes. Dobutamine has been known to improve RV function, and norepinephrine improves RV perfusion by increasing blood pressures. Inhaled nitric oxide, most of us don't have access to, and then as the last resort, you can use ECMOs in these groups of patients. So coming to the management. So if you have shock and you have high risk patient, thrombolysis is the way to go. Now look at this part. If the patient is low risk, you start with oral anticoagulants, and that is all you do, and you can discharge these patients early. If it is intermediate, you keep them in the hospital and continue anticoagulation. And if this is intermediate high risk, you start with anticoagulation, but if the patient worsens, you can resort to rescue thrombolysis. So our patient started from here. He was low risk. He was started on anticoagulation. He progressed to here because his biomarkers turned out to be positive, his RV dysfunction worsened, and he was already on anticoagulation. So this is a patient for thrombolysis, like all of you said, and you have an option of all of these, and TPA is the drug of choice if you really can afford it, but streptokinase and urokinase would also do. There is a high risk of bleeding with thrombolytics, always remember that. And now there are papers which suggest that half-dose thrombolysis with TPA is non-inferior as far as efficacy goes and cuts down on the bleeding risks. If your patient has contraindications, relative or absolute, you can resort to catheter-directed thrombolysis, or you can avoid thrombolytics completely and go for mechanical measures like thrombectomy. What is the role of IVC filters? Excessively used in the past. Some stability now, because cardiologists probably have understood that we also understand this subject, and that is where I would like you to draw the line. Please don't use IVC filters in patients with thromboembolism, and if you do use them, only use retrievable filters. The only indication is proximal DVT with contraindication of therapeutic anticoagulation, a failure of anticoagulation, a complication of anticoagulation, or a contraindication of anticoagulation. These are the only 3 indications. You try and remove the filter as early as possible and try and initiate anticoagulation as early as possible, because the risk of thrombosis of the filter also increases as time goes by. What about intermediate high risk patients and thrombolysis? And this was a trial which came out in the New England Journal, which compared this thrombolysis in this group of patients, that is intermediate high risk, not the high risk, and they used tenecteplase with heparin versus pure heparin. And what they found was the hemodynamics were better, but the incidence of major bleeding was high. And it clearly came out that for intermediate high risk, you should not resort to thrombolysis as your first option. Try anticoagulation. If the patient is worsening, then it might be a good option, like we did in this patient. So this patient was thrombolized. He was shifted out of the ICU as he got better. He was shifted back to enoxaparin, continued for 7 days, continued to improve, and the decision to discharge the patient on oral anticoagulants was now taken. So, which anticoagulant would you prescribe for this patient? And you have 4 options. Okay, fine. Let's see what the literature has to say. So there are 3 phases of treatment. Initially, you start with parenteral anticoagulants, but now we have option of giving oral upfront. Then you have long-term anticoagulation for 3 months, and in certain groups of patients, you resort to extended beyond 3 months of anticoagulation. This is how you treat. This is secondary prophylaxis. This is primary prophylaxis. There is no primary prophylaxis. Sorry, that is secondary prophylaxis. Guidelines say that all 4 of them, the DOACs, are equal and they are better than warfarin. So choose one, but preferably avoid warfarin. Cost is a major issue with DOACs, but generic brands have started coming in. So if possible, prescribe DOACs as compared to warfarin. There are several advantages of DOACs over warfarin. I will not go into details about them. These are the 3 which are available to us in India: rivaroxaban, dabigatran, and apixaban. There is no head-to-head study which says that one is better than the other, so you have a freedom of choice to choose one out of these 3. But in certain situations, one DOAC would probably be superior to another. Say, for example, extended anticoagulation beyond 3 months, the maximum data is with dabigatran. If you want to avoid heparin completely, then the trials use rivaroxaban and apixaban up front without heparin. Once daily therapy, if the patient wants just 1 tablet a day, rivaroxaban is the way to go. There was a high incidence of coronary artery disease in the dabigatran trial. So if you have a patient with coronary artery disease, rivaroxaban and apixaban are the drugs. The least incidence of GI bleed is with apixaban. So if you have a patient who has underlying some kind of gastropathy, you can use apixaban. And if you need a reversal agent, now we have idarucimab for dabigatran, which makes it a safer option. There are certain drugs which you should always remember when prescribing the DOACs, and there are significant interactions. So please memorize these drugs when you're prescribing DOACs. So this patient was started on dabigatran. It was given for 3 months, and a compression ultrasonography repeated at 3 months showed no DVT. What will you do now? Should you stop dabigatran, continue it for 1 year, shift to warfarin, or use aspirin? Stop and continue. Polls apart. A lot of you didn't vote. Anyway, so let's see about this. So there is something called provoked venous thromboembolism and unprovoked. Provoked is when there is a risk factor, and unprovoked means de novo. There is no risk factor, or the patient has active cancer, thrombophilia, or family history. That all falls into unprovoked. In patients who have unprovoked venous thromboembolism, usually we try and extend the duration of anticoagulation. So for unprovoked venous thromboembolism, right now we tend to anticoagulate beyond 3 months. For all other conditions where there is a reason for thromboembolism, 3 months is the optimal duration. It's a reversible cause, so you can stop at 3 months. In patients where we extend anticoagulation, there is always this risk of bleeding versus prevention of recurrence. But remember, in unprovoked, if you stop anticoagulation, the recurrence at 5 years is extremely high, 30%. So the moment you stop anticoagulation, unprovoked venous thromboembolism tend to recur extremely in high numbers. So how do you choose patients in which you would want to continue anticoagulation? Are there some prediction rules? Are there certain criteria? Right now, there is no foolproof system. So you discuss with the patient about benefits of preventing recurrence versus the risk of bleeding. And you can use the D-dimer as a tool to help you decide. So 1 month after stopping anticoagulation, if the D-dimer is rising, it is better to restart anticoagulation, because this is a patient who would end up having a recurrence more likely than a patient who doesn't have a rising D-dimer. Aspirin is a safer drug, but it is also a lesser effective drug. But in case you want to continue with aspirin, it provides 1/3 the protection of a DOAC. So it's better than useless, but it is not very effective. So this patient, after risks and benefit discussion, we decided to continue for 1 year. And the last question, would you have screened for hypercoagulable state in this patient? This is an elderly gentleman with no risk factors. Yes, 25,000 for one hypercoagulable state. Do you know that? Fine. Data states that there is no benefit in screening each and every patient for hypercoagulable state. Please don't waste that money. It is indicated only for specific groups of patients. So patients who are less than 50, also less than 45, or with a family history of VTE, or if the patient has recurrent venous thrombosis, or patients who have thrombosis in unusual sites, portal, hepatic, or cerebral vein. These are the patients group where you screen. Otherwise, don't waste that money. Always remember, if you screen, you need to have 2 weeks of anticoagulation before you screen. You cannot screen on anticoagulation. So either you screen before starting, or you stop, wait, screen, if required, restart. Testing for occult malignancy, also not very mandatory, although there is a 10% chance, just a basic screening. That means a blood workup, a chest x-ray, an ultrasound of the abdomen, a per rectal and a per vaginal examination, and age-appropriated screening for that patient. Say for an elderly gentleman in the US, they would do a colonoscopy, that's fine. But nothing beyond that. Only for high-risk groups do you go for a PET scan. Just because you think it is an unprovoked VTE, I think there will be a malignancy down the line, let me do a PET upfront. No, please don't waste that money, it's not going to add up. Hyperhomocystinemia. All of us look at homocysteine levels and all of us find them to be elevated and all of us treat it with folic acid and vitamin C. Probably no data to say that it works. Hyperhomocystinemia is a cause or an effect we do not know, and treating it does not prevent recurrences. So take home advice, look at it, but observe it, not necessary to treat it. So to summarize, this is what I have told you today, and sooner management of pulmonary embolism will be a multidisciplinary thing involving all of these people as we treat in the ICU. Last but not the least, always prevent, prevent, prevent. Thank you.
Do we have to do the venous Doppler before stopping the anticoagulation if we are giving it for, say, DVT? And we want to stop it after, say, 3 months?
An excellent question. I'll tell you why. So, suppose you've completed 3 months. Till date, we didn't have DOACs, so we used warfarin. Even with the best observation with PT-INRs, the time in the therapeutic range for warfarin in most patients is less than 60%, which means that most likely, even if the vein has recanalized, there will be residual thrombus. So when we were using warfarin, although the guidelines don't say screen at 3 months, but I would always be conscious because I knew my patients would have been fluctuating in and out of the target INR. And that is why, basically, for my satisfaction, I would screen. Now the problem is, suppose you pick up a residual thrombus, that is the issue. Would you extend anticoagulation or would you stop? Again, the incidence of recurrence from that residual thrombus can vary from patient to patient, and sometimes residual recanalized vein will not lead to recurrences, and there are times which will coagulate. So the decision to probably continue would be based on risk factors rather than the residual thrombus load. But if it is a proximal DVT and there is a large clot burden which is left, I would prefer to continue it, because these are the patients who will eventually develop chronic thromboembolic pulmonary hypertension from recurrent thrombi. Now, cut to present. We are using DOACs. I know they are fire and forget drugs. So our TTRs are no longer a concern. And in given situation, it is not mandatory to screen for a Doppler in today's world. Having said that, each to his own. So if you really want to, you also have to understand that if you pick up a residual thrombus, it will only confuse the issue further. Yes. So literature says that at one year, if you repeat a CT pulmonary angio, after you have anticoagulated for 3 months, 15 to 30% patients will have residual clots in the pulmonary vasculature. We do not know what that means. It is not chronic thromboembolic pulmonary hypertension. So again, if the patient is well, there is no hemodynamic compromise, he has resumed his exercise tolerance to his previous best, there is no clinical indication that there is significant residual thrombus load, I would not do a CT pulmonary angio, because again it confuses me further. Having said that, always the first 2 years after you stop anticoagulation, keep on watching these patients, because the first 2 years you will probably have recurrences, and these patients might still go on to develop chronic thromboembolic pulmonary hypertension in the unprovoked group, not in the patients who had risk factors and were reversible. Yes? So the D-dimer was done after the X-ray. So there was a minimal pleural effusion. And in India, a minimal pleural effusion is tuberculous in all contexts. So actually, to proceed for a CT pulmonary angio in this patient without a D-dimer would have been extremely, I would probably think twice, because it costs around 10,000 bucks in my city.
What is your take-home message on use of DOACs in subset of patients who have active cancer and DVT, PE or port thrombosis?
So till now, the CHEST guideline, which came out in 2016, we had no trials for DOACs in cancer, and the recommendation was LMWH is superior to warfarin. DOACs were not tested in cancer, so we had no data. By 2017 and 18, we have 2 drugs, edoxaban and rivaroxaban, which have been tested in patients with cancer, and they have been found to be equally effective as low molecular weight heparins. So probably by the next guideline, we will have that data. Till now, the data, the literature or the guideline says LMWH for 6 months. Dalteparin is the drug of choice. First month, 200 international units per kg. In the remaining 5 months, 150 international units per kg, followed by oral anticoagulant. That is what the guideline says, provided the cancer still exists. But now, because of the logistic issues with prescribing LMWH for 6 months in cancer patients, also the fact that cancer patients seem to be living longer, and prescribing LMWH for years together is not possible, and the fact that we have data which says rivaroxaban and edoxaban are effective in cancers, we can and we should switch to one of the DOACs.
Filters, IVC filters.
So primarily you can retrieve them in 3 to 4 days, but you can keep them maximally in for 4 weeks. Ideally, because then if you have started anticoagulation, you don't need them, and if you have not started anticoagulation, they will be nidus for thrombi.
Okay. Thank you.
Okay, so guidelines 2019 to an end. Thank you.
I would like to request Dr. Vijay Amrutkar sir to kindly felicitate Dr. Harjit Dumra.